Our next speaker is Dr. Sanjay Pandey. He has done his MBBS, MS from Cuttack and MCH from Pondicherry. He is head of andrology and reconstructive urology since 2009 and is a consultant robotic urology and gender reassignment surgeon at Kokilaben Dhirubhai Ambani Hospital. Dr. Pandey has undergone advanced training in Italy, Germany, Belgrade and Korea. He was associate professor at SRMC Chennai for 8 years. His interests are botulinum toxin in urology, MRK syndrome, prosthetics, incontinence. Currently he is attached to gender dysphoria, nocturia, enuresis and ICBPS clinics at KDH. Over to you, sir.
Thank you, Malcolm, respected chairpersons. Am I audible to you at the back bench? Am I audible to you back there? Thank you so much. I'll raise my pitch and voice if you tell me so, because I'm fresh. I just came from the hospital. And thank you for inviting me again. Memory goes back to Weston and I'll talk about that in a minute. But let's look into what you do and what we combine together do. That means at the Kokilaben Hospital, where 15 years ago I came to Mumbai and to the hospital. I salute all of you because you are very close and a happy hunting place from where I've got a lot of work to do. So Malcolm 2023, we carry greetings from Kokilaben Dhirubhai Ambani Hospital. After me is our illustrious heart of the hospital, Dr. Vidyadhar Lad. So in his shoes, I take it forward to say that every life matters, life at the bottom. Out there, we go down directly to the urinary tract. So greetings of sunshine and greetings of pink of health, because it's historic for us to be 15 years non-stop into this city, into this aspect where we took health by a storm. We looked into aspects of care and looked into various sciences. We still have miles to go because we combined together. Friends, the good news is I've only got 24 minutes, which they have said now it is 19 minutes. So the bad news is time will fly very quickly. So when I bring greetings to you to this Malad Medical Association, it's a little historic because you're looking at resolving to evolve, and evolution is a regular phenomenon. I remember that appreciation which you sent to me 5 years ago on your 25th Malcolm. So it actually it's quite close to my heart. When I got a chance to come in here, I said, we will stay back on Sunday to actually grace and probably meet our friends at Malad Medical Association. So 24 years in urology into my 25th year, all that I do today is all will be in a nutshell in a very short session that I take forward. So dial U for urology, and a massive subject called urology and andrology comes to picture. It's huge. All of you in this audience is a urologist. If you don't treat UTI, if you don't treat prostates, you don't treat incontinence, then I'm sure you're not a urologist, but each of you do this. And therefore this session is for you. This session is for you because lots of changes have happened in the world and I do a bit of it out here. Let me take to you in 2023 what we have brought back to India and brought back to Kokilaben Hospital and to all of your colleagues. Warding dysfunction is an amazing, difficult phenomenon. Something where we try medicines, we try diapers, we try medications, we try surgery. But friends, right now, sacral neuromodulation is back after a gap. That means we did not have this interstim device, which means we didn't have a pacemaker for our bladder and for our pelvis for quite a while in India. What am I talking about? I'm talking about sacral neuromodulation. Listen to this very well. I'll speak about this in 2024 lots when we get more and more good results happening. The last patient we did 3 weeks ago was from Borivali. Yes. So let me talk to you regarding the awareness is a key to this affair where refractory neurourological states, long-standing diabetes, long-standing spinal and brain diseases, and long-standing urinary and fecal problem which have not got corrected. Mentioned there, refractory overactive bladder, refractory hypotonic bladder which doesn't contract at all, and you and I are at the mercy of a catheter or clean intermittent self-catheterization, or a pelvic pain which is because of the nerve issues, or fecal incontinence which is again because of neuromodulation, can be changed completely. That means like you have a pacemaker of the heart, like you have a pacemaker up in the brain for deep brain stimulation in Parkinson's. You today also have a pacemaker in the pelvis which was always there. I probably would be guilty to not having done it after having done 4 cases in 2010-11 because the company withdrew for a short while in India called Medtronics, whose urology segment went off. Now this is one of the few countries in Asia Pacific where they're holding on to the program only because few of us in the country do this program. So what happens here is we are actually implanting a pacemaker in the pelvis. What we do is we neuromodulate the S3 sacral nerve by just a puncture, feel that, put a lead out there, and once you have done that, we are in a situation to actually look at and put a lead, a specific lead. Once that has been done, we are in a shape to actually place that battery or the implant, which sadly costs 8.5 lakh rupees. It's expensive. This battery can last 7.5 years is what has been tested. So this battery is then implanted, and once the battery is implanted, the patient actually gets the final result, which other means when we tested it out in the first session 7 to 15 days ago and put the test implant, we get to know if the patient is going into a neuromodulation, which means refractory overactive bladder not responding to anything starts improving, refractory incontinence or refractory fecal or urinary incontinence stabilizes, hypotonic bladders get modulated and they attempt to contract, and a patient can do a double voiding instead of living on catheter and living on infections. And finally, patients with bladder pain or with pelvic pain syndrome where there is no result and painkillers and epidural anesthesias don't help, the neuromodulation happens. So this is something which I want to take you forward. We have done a total of 7 cases in Kokilabin Hospital only, partly because people feel that the financial planning which the two wonderful gentlemen and lady did here, Mukesh and Nehal, is not for keeping them in the pocket or giving it to other banks. It is for ourselves. So if we have money and we can afford a treatment, the treatment is available in India today. That means we can do sacral neuromodulation for refractory states of incontinence, fecal or urinary, loss of bladder contraction power, hypotonic or pelvic pain. A very important adage that you need to take forward. Friends, we quickly go back to prostate health because each of you treat prostate. You do get good medications around and patients do well. But I believe that prostate is not about the size. It's about the occlusion to the urinary passage. So after 40s, 50s, all men here in this august audience and everybody in this world, which includes Mahatmas and me and you, all of us will go through a urinary change which we refuse to believe. It's a progressive slow change up the ladder. We don't believe till we have all the hairs grey, we don't feel they are old. Prostate is an occlusion to the phenomena where the urinary passage is going down. And each of us as patients in this Malad Medical Association who see you have expectations. They think Dr. Pandey did not do a good TURP even if they pass urine from here to Pakistan. The flow may be good, but the issue is a modern patient will bend you like Beckham. They make you expect so much or the expectations is huge. So let me tell you, a 20 grams prostate and a 200 gram prostate, both are equal to me. They cause an occlusion and you can't pass urine, so don't believe the prostate size all the time. A small prostate also can block and a large prostate may not block. For example, let's look at a video of this place. This is a video of a patient. I wish it played. Okay, if it doesn't play, it doesn't matter. If it plays, you would see something. Yes. So just have a look at this cystoscopy for getting an idea. The prostate is small. Ultrasound wise, 22 to 25 grams prostate. Recurrent UTI, discomfort, not able to pass urine. One fine day in ultrasound many years later, picked up a bladder stone. You can see the prostate is occlusive. So occlusion of the prostate is more important. The bladder is getting trabeculated. And there's a stone sitting in the bladder. It didn't come from the upper tracts. It has formed because of stasis in the urinary passage. This man is being treated for recurrent UTI. And on the right side, I'm doing a bladder neck incision. So that is state of art. Not about giving him Urimax all his life and his bladder continues to contract, becomes a stasis. So we want to give cure to also youngsters in their 50s and 60s and get them sorted out. It is not that everybody needs a medical therapy. So it's very important for us to know that we can open a prostate in that amount of time. Entering and probably opening in the prostate, which is occluding around, is what was important for you to know. I move forward and say what is in and what is out in BPH. Now a lot of young men in 50s, 60s agree not to undergo a TURP because ejaculation will be lost. उस उम्र में बच्चे पैदा नहीं करना है. So why about so much about ejaculation? We don't disturb your erectile function. But people get worried. And today we have got evidence across. I do it for 17 cases in 2022 and 2023 who were in then 40s and 50s getting Urimax for years together and passing urine with difficulty. Actually underwent a prostate surgery, which I call it as ejaculation sparing prostate surgery. The ejaculation is preserved, which is probably the complication that people are scared about, and we continue doing a lot of all that. So you can see that there are 2 TURPs here. I'm sorry about the videos around, but if you can see them, I've just completed a TURP, and you can see that I'm sitting at the Veru, Montana. Allow this video to play out. And then you will find that I have spared the ejaculatory mechanism or the premontinal tissue. In doing so, the ejaculation is preserved, the flow gets better, and you don't have to continue Urimax all your life. Extremely important idea that one needs to know. And then, for very large prostates that you refer, which are 100 grams, 150 grams, 200 grams, there's no need to do a TURP all the time. The urethra is the holy grail which suffers when I operate beyond 45 minutes to 1 hour. And if you continue to do a longer surgery of a large prostate, I think it will suffer. This is a large prostate by all practical standards. Have a look at this prostate. This is robotic work. which in the last 7 cases who were prostates more than 150 grams, we entered through the abdomen with 4 ports robotically, opened the bladder, brought the prostate out, and you can see the entire prostate in the abdomen. The urethra has not been touched. He is continent, it's almost bloodless. You won't see any blood there, except that there is a little bit of redness all around. So that's the entire prostate. The era when we used to do finger dissection around is what can be done robotically. Only 7 patients have undergone this in 2023. So out of what about 250 that we must have done. These are the patients with huge prostates. You need not go inside and do a TURP, give them a stricture urethra or tightness in tight urethra, which is important. That's something which is purely a state of art. We continue doing it for the right kind of patients who deserve to do it. So friends, while this is all being done to a very high level of sacral neuromodulation and prostate surgeries in individuals who deserve it, it could be TURP, it could be HOLEP, urethra preserving, continence preserving, ejaculation preserving. Something which you do regularly is about warding dysfunction. That means we need to get a control of urine, need to have a good flow. If anything goes wrong in the storage phase, that you all are seated very easily here because the bladder is storing like a bag, then it could become an overactive bladder. If anything goes wrong in the emptying phase and the bladder cannot empty, then it's probably a hypocontractile bladder, which can happen in spinal diseases, which can happen in long-standing diabetes mellitus. So friends, this contraction relaxation basis, if it goes wrong, then that's called overactive bladder. All of you see something called as incontinence of urine, where somebody complains of increased frequency, urgency and urge incontinence. Sadly, where the whole pathophysiology has gone wrong. That means there is inappropriate contraction of the bladder at odd times and odd hours. You're sitting in a queue, you may be in a bus, you may be in a bank or in a clinic. The bladder contracts erratically and translates into huge amount of agony and distress where urine leaks out. A very, very common phenomenon. 9 to 43% of Indian men and women leak urine at odd times and odd hours, and we don't even speak of. So susu and sex is never spoken up in public because we don't speak up. It's something a taboo. But people are living in agony of frequency, urgency, urge incontinence, nocturia, something where we had only one medication before, the group of drugs called anti-muscarinics, which were actually not taken up well because they had got dry mouth and constipation and stuff around. People would discontinue all therapies. When I met at Malad recently, I did talk about beta-3 agonist called mirabegron, which is a safe drug. You can practice that by giving a 25 and a 50 milligram in the morning. You can go to the full dose or can combine with soliferacin. In other words, it does not in any way interfere with the urinary mechanism. So I think I remember I gave a tip and trick which I carried back today. If somebody had got a lot of urgency, can't control, compelling desire, have to pass urine, we will give them a soliferacin 5 milligram every day in the morning. If somebody has got a lot of frequency of urination, give them mirabegron. Mirabegron will silence the bladder, bring about some sanity. Somebody is having a gross urge incontinence, leaks urine multiple times a day and night, cannot control urine. Probably give them a combination of mirabegron plus soliferacin in the morning itself. They'll be good enough. You should follow these patients closely. Maybe if they're obstructed males, you could see a uroflowmetry. I would love to do a urodynamics, look at the residual volume and see that we are not leaving them let a life of diapers. But not everybody will be treated by this. Subset of patients would probably suffer and they require a study called urodynamic study, where the bladder is erratically contracting while the bladder should fill up and resilient. And these kind of patients who are refractory overactive bladders, I jumped the gun and told that we can do sacral neuromodulation. But there was a therapy which I practiced for last 17 years, which is called botulinum toxin in the bladder. 100 and 200 units of botulinum toxin can be placed in the bladder, and that as it is injected intravasically, the bladder actually mellows down. Instead of taking the tablet every day and still not getting the result of combination therapy, these patients actually get a therapy of the injection which lasts 6 months to 9 months to even 1 year in few patients. So neurogenic patients of spinal kind and those who leak and live on diapers, or frequency, urgency, urge incontinence not responding to this, injection of botulinum toxin, 20 minutes of the work, the effect starts in 2nd to 3rd week and people are dry anything between 6, 9 and even 12 months. So it's an effective therapy instead of taking every day and getting a side effect. So it's all for us to understand that botulinum toxin injection has got multiple indications around. I probably in the era when I started doing this in Chennai and then came into here, I wrote the largest chapter in the book, the textbook of this subject around. And I still feel proud that we can go up the ladder from here. Failures could go to sacral neuromodulation. Friends, we forget about women, which should be the prime talk all the time. Stress incontinence never happens to men till I injure a sphincter doing a radical robotic prostatectomy or a TURP. But stress incontinence sadly is a female innate phenomenon. God made women different from men. I can't talk that today, but there's a huge subject of how God was partial when he made men compared to women. Women develop recurrent UTIs more frequently. They develop incontinence, stress and urge. Men don't develop it. If a man develops recurrent UTI, there are only 4 reasons. Either a phimosis, or a stricture urethra, or a bladder outflow obstruction because of prostate enlargement, or a hypocontractile bladder where the bladder is not contracting, not pushing out. There's no fifth reason a man should develop in recurrent UTI unless he's a diabetic of poor control. They are the reasons for men. Women sadly develop in UTI from the birth till they are around in this world, partly because of friendly neighborhoods called vagina and rectum which have got bacteria, and the soil, the introitus, unfortunately bacteria can move in. More so in postmenopausal women. When you look at stress incontinence, in the perimenopausal age group and even younger women, coughing, running, jumping, laughing, all is going to be difficult because they are isolated because of leakage happening around. Many of these women in prime of life may be CEOs and heads, but they still live a very life of isolation. So give them laughter. Their best medicine is about doing a kind of a surgery which I do few times per month. Sadly, I should do 100 times per month to get all women dry. We miss out because women don't come up. I do more for those women who belong to a community where they have to bend down to do namaz and they cannot because they are ashut. So they come more frequently and want to be dry. Friends, this is a real menace, female urinary incontinence. Do we let them live with incontinence or do we take their incontinence away as an important phenomenon? While I talked about urinary bladder in women, my heart goes out on a subject which you all should hear very patiently for the next 2 slides. More common in women is a disease called interstitial cystitis bladder pain syndrome. What does it mean? Pain on bladder filling. Nobody in this audience has got pain when there's a bladder filling up. What happens to somebody whose bladder, as it fills up, gives a pain? Because the bladder lining is diseased, the bladder lining doesn't let the bladder fill up. So they learn a force frequency urgency. They get up at night not to pass urine, but they get up at pain. So it's pain all the time when the bladder undergoes a change in the interstitium, and sadly the bladder can contract. They go through all that and sadly what are they done? They are treated wrongly as UTI, overactive bladder and what not. And that's something which you need to wake up to this slide, which probably could be important. If you see women coming with urinary complaints or people whom you want to identify as interstitial cystitis bladder pain syndrome, if they complain of pain in the lower part, there could be many reasons: chronic pelvic pain, the endometriosis, etc., etc. There could be people who could be having urinary complaints. So imagine urgency, frequency, urge incontinence, painful bladder filling, relieved when they pass urine, they feel better, and something which you could pick up. Then don't treat them wrongly as overactive bladder, as recurrent UTIs, the urine cultures, something which is important. Let me move on quick. I've got few minutes. Stones is not uncommon to our colleagues in Balcon. Stones in the kidney will go through only 2 processes. Will grow, become big, and I will do a PCNL or puncture and remove them by a puncture technique. Or they will fall down and cause trouble to you on 31st January or on celebration nights where you have a stone blocked all the time. Ureteric stones are never acceptable. They may not always be expelled. But if there is a large stone, we normally go and puncture and enter the kidney, and once you are there, we do a PCNL. This happens few times every month in silent stones grown and become so big. These are big stones silently growing. But the small stones falling down, attempting to treat them if they are diabetics, if they are in infection, if they are in sepsis, pain, or if they are in single kidney is dangerous. I think we should look at sorting ureteric stones out. But what about small stones? We see a lot of these small stones. Imagine this, small stones in the kidney. This was an era where we didn't have that, but today, beyond lithotripsy, we have something called as flexible ureteroscopy. We can enter the kidney like the endoscopes, enter and probably remove. He's equal to 4 patients, 2 on the right, 2 on the left, and some buds are still growing. So we take a telescope, enter inside, powder, laser, and remove the stones, and that's how it is. So this works in our favor. So if you have got, this started with marine engineers, sailors, air hostesses, and with pilots around, but it's for common people too. If you have got a stone in the kidney, the no way it will come out through the mouth and nose. It will come down through the ureter, which is a 2 mm pipe which God made. Many a times can be troublesome around. So let's concede that RIRS or retrograde internal surgery is a requirement. You have a stone of 5, 6, 7, 8, 9, 10 mm in the kidney. Giving them Nereans stone will not work. Take it from me. It is important. When we look at all this, we also look at quality of life diseases. Nocturia for our parents and grandparents is a disaster. They sleep less at night. They get up multiple times to pass urine because the bladder produces more urine as a result of change in the arginine vasopressin mechanism in the bladder and the kidney. So if that happens around, I wrote a big lie on a newspaper 2017. Nocturia and enuresis is treatable completely. And people came up and said, is it treatable? My child is bedwetting for 8 years. I go to a pediatrician for cough and cold and never tell. And that is something which we need to look into. So friends, bedwetting is treatable completely. I run a complete clinic on nocturia and bedwetting as a walk-in clinic. And nocturia has got many reasons, and you are important. Nocturia doesn't belong to a urologist because look at it, everything from uncompensated heart disease to diabetes mellitus to estrogen deficiency, polydipsia, and all those things are important for us to identify. They all cause nocturia. Unfortunately, we drink tea, coffee, alcohol at night and they all produce diuresis in the kidney. So diabetes and urologists have a very close relationship. I'll be finishing in 2 minutes starting now. Global polyuria, nocturia, recurrent UTI and uncontrolled diabetes. Long-standing diabetes, even if well controlled, brings about a fibrosis of elastin fibers and bladder loses its contraction power. You on ultrasound find a high residual volume, you treat it as recurrent UTI because there's debris and dirt. Obviously uncontrolled diabetes also brings about end-stage renal disease and things which probably require a renal transplant. I need to look into that recurrent UTI in a male because of a stricture urethra or a narrowness which we repair very well by a urethroplasty. If somebody has a kind of a straddle injury or an injury where a stricture was tight, dilating will not work, we do an anastomotic urethroplasty. Somebody had a road traffic accident and if that urethra was completely blocked, we do anastomotic. These are all men. But don't forget, women also will develop stricture urethra. Recurrent UTI in a woman, if the urethra is tightened up, like you can see a urethra is very tight, there are ears and there is a head created in the bladder because of diverticulae. These are women who go through it. And therefore, various kinds of issues which women go through as stricture urethra is treatable and curable by a female urethroplasty. There's a huge evidence floating all around. Give me a minute to finish off this. I started at 5'7", so this is Peyronie's disease. It's very important I speak of this. Men search me on the YouTube from all over the world and come in. I operated 7 people from abroad because they searched me on the YouTube. Penis is okay, but it bends when you get an erection. What do you do with these men? There's a plaque which is developing gradually, and these kind of men cannot perform. They're morally very down, they're losing their partnership, they're in dilemmas. The penis is gradually getting bent, losing erections, losing morale, and they need a straightening of penis. 3 patients in Coquelin Hospital right now on the 14th, 11th and 9th floor have undergone a treatment for corporoplasty in the last 2 days. They have got straight penis now. So something which I need to take you forward is about straightening the penis without losing the erections. And the last part of it, probably before I talk one sentence on robotics, is male erectile dysfunction also is an important aspect which you see. Men come and tell you, I've lost libido, I've lost interest, I've lost desire, but they're also refractory in terms of loss of erection. Rupin Shah is a pioneer in this city and the country. He made India's first penile prosthesis, and there are hordes of other Americans and other people who got it. Penile prosthesis for refractory erectile dysfunction is to me 7 days a week. Sadly, they come in. There are issues about cost, insurance, but they get an erection after a trauma, after an injury, and after perhaps diabetes mellitus. So diabetes for more than 10 years takes away your vision, your kidneys, your bladder becomes hypocontractile and you lose your erections are sadly common issues which we need to be aware about. So there's a huge list of indications which I coined in 2022 for the Urology Society of India. All this is what we probably do for erectile dysfunction or refractory failing, trauma, injury, nerves, etc. etc. Friends, I come to a close telling you that andrology is a huge part of my work. I love doing it because men deserve something which they suffer. Urology as such is a core issue which I look at. Reconstruction is what I get into. But the last slide, if you allow me, is on robotics. Something which I started in 2010-11 with Urology. I didn't do cancers initially, but now from cancer prostate to kidney cancers to all kinds of reconstruction and gender reassignment surgery is all done with robotics. I won't take it forward beyond it, but everything which is reconstructive in robotics is something which is done by us. I will not go into videos and all kinds of partial nephrectomies, stricture, ureter, etc. and creation of vaginas for women who have no vagina because they're born with MRK syndrome, because God also goes to sleep and sends women down 1 in 5,000 without uterus and without vagina. So they have no menstrual periods, they cannot get married till they have a vagina. So friends, as I come to a close, it is important that awareness is the key to all this. We at Malcon connect with society very strongly. I feel that in Malad, in Malcon, from today onwards, they would say, I love my doctor at Malcon. Let's leave the urologist away because he knows all and he takes it forward. So I'm motivated when I come to Malcon all the time because there are motivators who motivate me. I get motivated by them too. But I think awareness is what was important, and therefore we believe in teamwork, you and me, you and us at Coquelin Hospital. Salute each of you in this audience because we come back here every time saying that while you resolve to evolve, we are evolving with you together. And by evolution is their experience, expertise and expectations are matched at Malcom. Thank you so much.